All right, this is the second installment of our chapter 25 discussion. We will look now at cyanotic congenital heart defects. So let's begin with a clinical vignette. There are a couple of mothers at the pediatric cardiology clinic, and they're discussing their little ones. One mother tells the other mother the story of her 5-year-old boy named Blake. At birth, Blake had a bluish tinge to his skin, and he had a continuous machine-like murmur between his shoulder blades. The other mother then proceeded to tell the story about her 12-year-old son, Paul. Paul was healthy at birth. However, whenever she breastfed him or when he cried, his skin turned pale and then it turned blue. Paul grew up, and as a child, he was not able to keep up with his siblings. He got out of breath very easily. And sometimes when he was really out of breath, he would squat down and that would help him recover. Later during a school physical, the doctor discovered he had a heart murmur. So both of these little ones, Blake and Paul, have cyanotic congenital heart defects. These will usually cause problems within the first 3 to 8 weeks of life. Some are more life-threatening than others. So there are 5 of these: persistent truncus arteriosus, transposition of the great vessels, tetralogy of Fallot, total anomalous pulmonary venous return, and tricuspid atresia. The first 3 of those, persistent truncus arteriosus, transposition of the great vessels, and tetralogy of Fallot, are outflow tract defects. They develop during the formation of the aorta and the pulmonary artery. So the heart begins its life as a tube, and it starts beating at about 21 days, well, 22 days of life. The upper part of the heart is the truncus arteriosus, and the inflated piece below it is the bulbus cordis. So this would be the bulbus cordis right here. And the truncus arteriosus would be up here, essentially. So let's call that truncus arteriosus. And this would be the bulbus cordis. Somewhere around week 7, so about 48 days or so after fertilization is completed, neural crest cells, which have migrated into the bulbus cordis, trigger the formation of the aorticopulmonary septum. The aorticopulmonary septum starts from these endocardial cushions, and they're going to grow upward like this. So there's one here. There's one actually over here as well. There's one over here. There's one right here between the 2 flow tracts. They grow upward, but as they grow upward, they spiral. So they grow up and they spiral, and they will form the aorta, which is connected to the left ventricle, primitive left ventricle, and the pulmonary artery, which is connected to the primitive right ventricle. Now, if this does not happen properly, you can have one of those 3 outflow defects: tetralogy of Fallot, transposition of the great vessels, or persistent truncus arteriosus. We'll start first with tetralogy of Fallot. So tetralogy refers to 4 features you must remember. The first part has to do with the part of the right ventricle wall under the outflow tract, what is called the infundibulum septum, is displaced anteriorly, like you see here. This is in this direction. That causes pulmonary stenosis. So it narrows the right ventricular outflow tract. So that would be number one. Number two, you have the narrowing of the right ventricular outflow tract. That increases resistance to blood flow, and the myocardium of the right ventricle, in response to this increased pressure, is going to enlarge. So this right ventricular wall undergoes hypertrophy. That would be number two. Consequently, on an X-ray, the enlarged heart looks like a boot. It's pretty hard to miss. It kind of looks something like that on an X-ray. It's quite hard to miss. Three, there is a ventricular septal defect. This hole between the ventricles allows the blood to shunt across during fetal life, where the right side pressure is the highest. Blood will shunt from the right side to the left side. When the baby is born, blood will now shunt from the left side to the right side. But as that right ventricle starts to enlarge, you start to get Eisenmenger syndrome, Eisenmenger, Eisenmenger syndrome, and now you'll get a right to left shunt. So now some of the deoxygenated blood bypasses the lungs and goes into the left ventricle and goes out to the systemic circulation. Fourth, there is a displaced or overriding aorta. That's number four. This overriding aorta, as you can see here, can obscure the outflow tract as well. So the level of cyanosis depends upon the severity of pulmonary stenosis. So unlike other cyanotic congenital heart diseases, congenital heart defects, some newborns are asymptomatic until later in life. For example, in our clinical vignette, we saw Paul. He had a cyanotic episode called a tet spell, a tet spell. So this can occur while feeding, crying, or running around in the playground. This causes spasm of this infundibulous septum that worsens the stenosis that causes cyanosis. And if the patient squats down, that kinks the arteries in the legs, that increases peripheral vascular resistance, that increases afterload, and it shoves these two outflow tracts apart. That leads to less blood shunting to the left ventricle, more blood going into the pulmonary artery instead, and it relieves the tet spell. So that leads to cyanosis, which is relieved by squatting down. Very characteristic of tet spells. Tricuspid atresia is a failure of the tricuspid valve to form. It either doesn't form entirely or it is very, very malformed. If it's absent, deoxygenated blood returning from the systemic circulation gets trapped in the right atrium and it can't reach the lungs. This is caused in many cases by mutations in the FOG2 gene, as you can see here. This condition, as you can see here, is completely incompatible with life unless there is an atrial septal defect where the blood can get now from the right side to the left side, and then also ventricular septal defect, so the blood can get from the left side into the outflow tract and to the lungs. To make matters worse, this roundabout path that the blood takes severely limits the amount of blood that reaches the right ventricle. So the right ventricle atrophies, like you see here. The mixing of the blood, the decreased pulmonary blood flow contribute to the cyanosis. Transposition of the great arteries occurs, transposition of the great vessels, as it's also called, occurs if the aortical pulmonary septum forms but does not spiral properly. In this case, we get the aorta, which is normally connected to the left ventricle, now being connected to the right ventricle. The right ventricle, instead of being connected to the pulmonary artery, is connected to the aorta. So deoxygenated blood from the systemic circulation enters the right side of the heart and then gets pumped through the aorta out to the systemic circulation again. Oxygenated blood also from the lungs goes to the left side of the heart and then goes right back to the lungs. So we have two separate closed systems. That's the big part about this you must understand. Two separate closed systems. Two separate closed systems. Now, as you might guess, this is completely incompatible with life unless you have some way those two types of blood can mix. Typically, a patent ductus arteriosus lets deoxygenated blood from the right side of the heart mix with the oxygenated blood of the left side of the heart, and vice versa. You can also have atrial septic defects or ventricular septal defects that will allow blood from these two circuits to mix with each other. If you can get the oxygenated and deoxygenated blood mixing, you'll still have cyanosis, but that is at least compatible with life. Since the patent ductus arteriosus closes soon after birth, it has to be kept open. So these patients are usually, young patients are usually given prostaglandin E to keep it open, and that will keep this ductus arteriosus open and allows the two circuits to mix their blood. Total anomalous pulmonary venous connection is a strange congenital heart defect. In this case, the four pulmonary veins, which start their life at the lungs and they grow towards the heart and then they fuse with the left atrium. In this case, they fuse with the wrong part of the heart. So they will either fuse at the right atrium or they'll fuse with the systemic veins. So oxygenated blood from the lungs ends up on the right side of the heart. So for the fetus to survive, it has to have an atrial septal defect to allow blood to move from the right atrium to the left atrium and then from the left ventricle out to the body. So this requires an atrial septal defect for it to work. Since the right side of the heart receives a good deal of blood, as you see here, the heart will develop, well, the body will develop pulmonary hypertension. That puts more pressure on the right side of the heart. You can get right-sided hypertrophy. And so there's cyanosis, but this can also lead eventually to heart failure. The persistent truncus arteriosus is a result of a failure of that aortical pulmonary septum to form. So it either doesn't form completely or it doesn't form at all. Since the neural crest cells either didn't migrate to the bulbous cordus or they just didn't do their job and formed the septum. You now have a single vessel connected to both the left and the right ventricle, and a incomplete ventricular septum also is seen as well. This is very common in people who have a condition called DeGeorge syndrome. It's a genetic condition. DeGeorge syndrome. DeGeorge syndrome will have this. And as you can see here, you get a complete mixing of blood from the left and right side of the heart, and they go either out to the systemic circulation here, or they go to the lungs. And this is, as you might guess, not terribly compatible with life. Let's talk a little bit about signs and symptoms. With the exception of tetralogy of Fallot, where cyanosis might not appear until later stages of life, peripheral cyanosis occurs in the limbs. It can actually be slightly normal in newborns. Central cyanosis are those cases where the infant's whole body is cyanotic and it's abnormal and should always be investigated. Other symptoms, so the cyanotic congenital heart defects will show central cyanosis. Other symptoms are difficulty feeding and failure to thrive. You can assess these with ultrasound. So after birth, pulse oximetry, an ECG, and a chest x-ray can help you diagnose a condition. Best choice for confirming a congenital heart defect is an transthoracic echocardiogram. Heart murmurs are associated with these congenital heart defects, and they might be the best clue you might get sometimes. So a tetralogy of Fallot and tricuspid atresia, they often have a ventricular septal defect. So you will hear a holosystolic heart murmur at the left lower sternal border. Transposition of the great arteries can occur alongside a ventricular septal defect, atrial septal defect, or patent ductus arteriosus. That presents as a continuous machine-like murmur at the left intraclavicular area or between the shoulder blades. Hypoplastic left heart syndrome is due to mutations in any of the genes shown here. The left side is severely underdeveloped. This manifests relatively early in life. It can be fatal if it's not treated. The child is usually treated with a variety of medications to lower blood pressure, to lower preload, afterload of the heart. And as you can see here, the left ventricle, which should be the main pumping ventricle, just fails essentially because it's so hypoplastic. This occurs with a variety of severities, but these kids usually need a heart transplant. These conditions can also result in heart failure if the heart cannot support the needs of the rest of the body. And this is a complication of many congenital heart defects. We already talked about Kawasaki disease, so I'm not going to read you the riot act on Kawasaki disease. Remember, this is a vasculitis of middle-sized arteries, tends to affect the coronary arteries of the heart typically. And remember that mnemonic, crash and burn. You have the conjunctival exudates. CER, you have a rash, usually all over the body. A, you have cervical lymphadenopathy. The lymph nodes, cervical lymph nodes, are usually about 15 millimeters in diameter, at least a minimum of 15 millimeters in diameter. S, you have a strawberry tongue, the beet red dotted tongue. S, you have a desquamating rash of the hands and feet. And then burn, you also have a fever. That's the crash and burn mnemonic. You have an unexplained fever in kids with a rash, especially if it occurs after viral infection. You should suspect Kawasaki disease. This condition is treated with aspirin. It's one of the few childhood conditions that's treated with aspirin and also intravenous immunoglobulins. can drive it to remission. And then kids can also get systemic sort of conditions if they have a heart defect. Systemic hypertension can ravage the kidneys and the heart and the retinas and other things like that as well. So some questions. The pediatric client has a cyanotic heart defect. Which of the following is a cyanotic heart defect? And you can see here, we talked about these here last time. So these are acyanotic. This is the only one that's cyanotic. So the answer here is A. The cyanotic ones include tetralogy of Fallot, transposition of the great vessels, total anomalous pulmonary venous connection, hypoplastic left heart syndrome, and tricuspid atresia, persistent truncus arteriosus, and so on and so forth. If you hear a machine-like murmur when performing cardiac auscultation on a 2-day-old infant, what's the most likely condition? Well, that machine-like murmur should really tip you off. It's patent ductus arteriosus. And remember, 90% of these cases are isolated. 10% of them are associated with other conditions. So you have patent ductus arteriosus, you may want to look for other congenital heart defects. So now back to our case study. So Blake was cyanotic at birth, and he had a machine-like murmur at his back. So he's got a PDA, but patent ductus arteriosus does not make you cyanotic at birth. So this is a patent ductus arteriosus associated with something else. Most likely, Blake had transposition of the great vessels. Paul had a tit spell, and he had to squat down to get away from it. And so he had tetralogy of Fallot. By squatting, that increased the afterload, decreased the left to right shunting, and increased the pulmonary blood flow.